Welcome to another Infection Prevention and Control podcast. Today I am chatting with Norma-Jean Robinson, who is an infection control nurse here at Northumbria Healthcare, about the work that she's been doing in regards to hydration. Hello Norma-Jean.
Hi Rachel, thank you for having me.
Tell us about your project work.
Infection Control Northumbria, North Tyneside Hospital, we take part in the monthly regional network meetings, and it's often chaired by the NHS, by an NHS England chairman or chairperson. So we were tasked with the project of developing a hydration idea in the trust to improve hydration, because what they found is that a lot of patients regionally are at risk of dehydration in the hospitals.
Okay.
Now, before we can collect or develop an idea, we need to obtain the evidence. Is there a problem in the trust? And if there is, how can we combat it? So what we identified was that 66% of patients in North Tyneside Hospital alone, over a 3-month period between January and March, developed a UTI, AKI, or both. So 66% of patients under our care were diagnosed and treated with one of these symptoms, which is often related to dehydration.
That's really bad.
It is.
So you've done a trial at North Tyneside.
Yes.
Do you want to tell us about that?
So following on from the data that I initially obtained, what we had to look at was the practices, the hydration practice on the ward. And what we identified was dehydration compliance issues. So the fluid balance documentation weren't being recorded accurately. But what does that actually mean when it comes to potential dehydration on the ward? There was no standardized routines with replenishing jugs of water or giving patients hot drinks.
So what was happening?
So domestics would hand out the jugs of water and the hot drinks on this particular day that I observed the practice. But one patient, for example, didn't drink the hot drink or touch the jug of water. So that patient, in effect, didn't have fluid for over 16 hours.
Wow.
Yeah.
So how was that highlighted? Just communication or documentation?
Well, that wasn't highlighted, and that was the biggest issue. IPC observed it and identified that as a cause of concern in our trust. So you asked about the pilot.
Yeah.
Moving on. So management agreed for me to pilot a hydration initiative on Ward 23.
Right.
So that's an elderly care rehabilitation ward. The same issues were identified with compliance, documentation, routine and knowledge. So the plan of action was to collect data on that ward. And initially what we identified was 57% of patients, 57, were diagnosed with a UTI, AKI or both on that ward in a very short period of time.
What time scale did you do it over?
4.5 months.
Wow.
Pre-pilot.
Okay.
So the plan of action was to identify visual aids and education, improve the patient's hydration status. So I developed a hydration group in the trust. There were 30 staff members from different disciplines: sexual health, clinical educators from the wards, podiatry. And what this allowed was a bigger scope of practice to have input into the poster, because hydration isn't just about IPC, it's about collaboratively everyone getting involved. So we developed a really bright hydration poster, because for me, how do I catch your attention? And we need brightness. How do I get the attention of patients on the ward?
Yeah, you do, because you become poster blind, don't you? And
Yes,
you need
do.
something that's going to capture. Right, okay.
And it's an A3 poster as well, so it's big enough for an opportunity of education there with the staff and the patients. So the other visual aid we had were pocket cards, and there were symptom checkers. I need you to be made aware of what a urinary tract infection is versus dehydration symptom. And if we can combine the two visual aids, we can prevent dehydration, we can prevent a UTI, we can prevent the escalation of an AKI. So the visual aids were done, and there was a 2-week pilot study. We got the interdisciplinary team involved: doctors, nurses, healthcare assistants, nutritional assistants, ward managers, matrons. And that was really important because we needed everyone to be invested in this hydration project. Urine charts were placed in all of the bathroom facilities, and we heavily educated all of the healthcare assistants and the nurses on the ward, and the physiotherapists as well.
Okay, so it was a full approach.
It was the full shebang because we needed everyone invested on that ward. It's a rehabilitation ward. Dehydration affects everyone, every member of staff. So I focused on the nurses first, and I needed to educate them about urinary tract infections versus dehydration symptoms, and educate them about using both tools together. The urine chart with the pocket cards. And then I focused on the healthcare assistants. Now for me, they were the driving force to implementing the change on this ward.
Why?
I feel like healthcare assistants are often overlooked in clinical practice. So when they learned and they upskilled their knowledge about dehydration, just the very basics about dehydration, such as dry mouth, dry skin, dark coloured urine, they're the ones who reinforce the change to pushing hydration on the ward. I didn't touch on UTI with the healthcare assistants because I'm looking at preventative ways. So with the physiotherapists, did they need to know about UTIs? Absolutely not. Stick to the basics of dehydration because then you can act quickly and prevent. Then we disseminated the pocket cards to all of the individuals. They were all educated on the wards. But actually, the issue that I struggled with was how much is enough of water, how much is enough of the fluid intake.
Well, that's interesting because my next question to you was that I remember as a student nurse myself that I've seen some information around 2 litres. Is that right?
So initially it was 1.5 litres to 2 litres.
Right.
But the evidence everywhere states a different amount.
Okay.
But what they don't take into consideration is how hot is the ward. Because when it's a hot environment, you're going to sweat.
Yeah.
They don't take into account the medication that the patients are taking. They don't take into account the level of exercise, the obesity, the age. So there's a lot of factors that do come into play. And one of the doctors said to me, you need to remove the amount that you're saying because you need to look at that individual's hydration needs by looking at the urine colour shades.
Yeah.
Because everyone has a different amount of fluid intake that will meet their requirements. So I didn't use an exact amount because actually the evidence differs so much.
Right, okay.
But actually just by pushing fluids, we reduced urinary tract infections by 46%.
Just, wow, on that ward?
On that ward alone,
okay.
Over a 4.5 month period. We reduced acute kidney injuries by 47%. And we reduced both combined UTI and AKI diagnosis by 25%.
That is a phenomenal figure.
It's massive, just by pushing hydration and focusing on dehydration symptoms alone.
What do you think was the sort of, I know you've mentioned obviously healthcare assistants, do you think they were fully the driving force or do you think it was the full approach that you've took?
I think it was a full approach.
Right, okay.
Because what we found was actually documentation improved because now they had an invested interest in dehydration. Our nursing force stopped dipsticking urine.
Okay. Well, let's talk about dipsticking.
Let's go.
Tell me about dipsticking. When should we be dipsticking?
We need to be looking at symptoms.
Okay.
Clinical symptoms.
And what are the symptoms?
Okay. Frequency.
Okay.
Urgency.
Right.
Hematuria. Delirium. There's a whole host of clinical symptoms. Pain, abdominal, flank pain. There's a whole host of symptoms, and that's why the pocket card symptom checkers are so important.
Yeah.
So my argument moving forward is, why do I have dipstick tests on elderly care wards?
Yeah.
And are they relevant and do we need them?
Because we skip the dip in the over 65.
Skip the dip. We shouldn't be dipsticking anyone who's over 65, okay. Exactly.
And what would be the impact if we didn't skip the dip?
Well, it shows.
Yeah.
Antibiotic prescribing.
Yeah.
Further antibiotic resistant infections. But actually misdiagnosing dehydration.
And that's the big key, isn't it? That we are misdiagnosing UTIs and, relying on the dip test to be the sort of hard and fast rule. And we aren't sending specimens to the lab and we are seeing overprescribing of antibiotics for inappropriate reasons.
Exactly.
Fine. So a few questions. Obviously, going back to your pilot that you have done on 23, what is the future?
We need to change the workplace culture.
Right.
Everyone is quite embedded in the way that they do things, but nothing's standardized. And we need a full hydration approach that is standardized across the trust when it comes to what do we expect when it comes to preventing dehydration. And that is ensuring that our patients get fluids, drinking the fluids, not just having fluids in front of them, and asking the question why they aren't drinking if they refuse to drink. Now, as we get older, we lose the ability to have the sensation of feeling thirsty.
Right.
So when our patients refuse a drink, we need to, ask the question why and problem solve and communicate at the earliest opportunity with our medical team. Because do they need IV fluid therapy in the interim? Do we need a different approach? What do they like to drink? Do we need to look at a water-based approach with food? Soup, yogurt, jelly to up the fluid intake.
Are we counting these products as fluid then on the fluid balance chart? Like that, because that was going to be my next question. Again, as a student, I remember that there was documentation around custard, that we could use custard as a fluid. Is that still the case? Can we still do that?
I think it's very important that we do.
Okay.
Because watery foods account for 20% of our overall fluid intake. So when we are looking at urine colour shades, do we need to be including food? Absolutely, we do, yeah.
What we talk. Where would we be recording this?
I think it's important to document it on the fluid balance chart.
Right, okay.
Because we need to look at the input and the output.
Yeah.
But on the fluid balance chart, I think we need to be writing the colour shade of the urine as well.
In the comment section?
In the comment section,
okay.
With who we've highlighted it or handed over to, and then obviously it's that journey, the patient's hydration journey, where we've identified that they've got dark coloured urine, we've identified that actually they're only drinking 400 ml in a 24-hour period, we've identified who they've handed over to. Now it's the next part of the journey. Now we're going to push fluids, we're going to have hourly fluid monitoring. Okay, they're not drinking, now the medical team now needs to get involved. Diagnosis, and the next steps.
Yeah.
So we do need that holistic side of care, but we really do need effective communication amongst the team.
I've got a random question, I'm just going to throw it out there. What happens if someone's nil by mouth?
They'll be nil by mouth for a reason.
Okay.
It's usually a surgical medical reason. The medical team will be fully aware of the why. Have they got a blockage? Do they need enteral feeding? Do they need a swallowing assessment? And obviously everything will be put into play in the patient's journey. So nil by mouth is very difficult, but it's the why. But it's okay to challenge. So if you feel that your patient hasn't had any fluid or nutrition in quite a long period of time, 24 hours, 48-hour period, we need to be questioning and challenging because you're highlighting your concerns that now need to be acted upon.
Right, okay, that's fine. And is there a standard length of time that someone should have a drink? You know, should I be drinking every half an hour? I'm obviously looking in this room and you've got a huge bottle right in front of you. How often should I be having a drink?
Again, the evidence varies. There is no evidence. Okay. Evidence is pretty shocking when it comes to hydration because the focus is on usually UTIs.
Right.
So there's no scientific evidence anywhere to say you should have 200 ml every hour.
Right.
You should have 300 ml in so many hours. There's no evidence out there. So the NHS might say 6 to 8 glasses of water in a day. But what does that tell me?
Oh, yeah, what does it tell you?
What does it tell me?
What size glass have you got? You know?
Exactly.
Yeah.
So that's why I'll always go back. However, there will be some issues because some scientists out there will say, but Norma-Jean, depending on what we drink, might influence the colour of the urine.
Yes.
What medication or vitamins we have. However, what this pilot shows is that urine colour does change. We can prevent dehydration, therefore we can prevent a UTI and an AKI, which means quicker hospital admissions.
Yeah.
It means less money spent within the trust, but cost saving. But from a patient safety point of view, we need to protect and safeguard our patients when they're under our care.
Yeah, absolutely. So obviously you mentioned the contents of what you were drinking there. So, my next question would be things like teas, coffees, fruit juices. They're obviously all included as part of, the fluid balance. Is that right?
It is, but again, going back to what we observed. So what I found on pretty much all the wards in North Tyneside, our trust has got different cordials,
right.
But you go into the wards and the patients have just got water. So when I had a word with the patients, Billy, I've noticed that you haven't had anything to drink from your water jug. What do you drink at home? Would you prefer orange juice or blackcurrant juice? And straight away the conversation flows. Well, actually, I've never had water at home. I don't like the taste. There is no taste and I don't drink it.
Yeah.
But the minute that I put some cordial in, then you started drinking more fluids.
Right, okay.
And it's just about really providing that holistic approach to hydration of the asking the why. What do you prefer to drink? When do you drink? Is an opportunity to give patients fluids around, not just during the fluid times with the trolley, but at other times as well. Mm-hmm. Do we offer, I remember years ago we used to offer patients Horlicks on an evening.
Yes,
and they used to love it. And I think that some wards have stopped that. They don't do an evening drink, and I don't understand the why.
I remember you used to have options, hot chocolate,
Horlicks,
warm
absolutely.
Milk. Yeah.
Yeah.
Right, so obviously looking at it moving forward, you've done the project. What's going to happen for other wards? Obviously, it's been really successful at North Tyneside. Is it going to be rolled out to other areas, or we're going to be providing everyone with the pocket cards? How's the education going to be cascaded moving forward?
So we aren't a huge team, but we work within a very large trust.
Yeah.
I think the plan of action is it's going to be rolled out trust-wide with the urine charts in all of the bathroom facilities and the pocket cards disseminated to all the staff. But there needs to be a drive on education. I think IPC will be promoting this during the focus weeks.
Yeah.
It's going to be discussed during the stat and mandatory training. So we have got a few areas where we can promote it, but again, it's got to come from seniors as well.
Yeah.
What are the ward managers doing to continue to sustain this project?
Yeah.
Because we can't be the eyes on every single ward.
Yeah.
So it's got to come from the senior staff, all staff actually, whether you're a healthcare assistant, you're a nurse, you're a doctor, your management, it's got to be a full drive. And like I said before, there needs to be a shift in the workplace culture when it comes to hydration.
Yeah, yeah. Great. So how can staff contact you if they've got any questions?
So they can contact the IPC team via telephone, everything's on the intranet.
Yep.
Or just send us an email.
Okay.
And somebody from the team will then either reply to the email themselves or I'll reply to the email directly.
No problem. That's fantastic. So obviously if there's any staff out there that want to take it on as a possible QI project, that would be fully supported from us as the IPC team. And obviously if they've got any questions, then they can contact us via email or telephone. But thank you very much, Norma-Jean.
Can I just say one more thing?
Yes, of course you can.
So we do have a hydration group.
Okay.
And I think it's really important to continue spreading the word.
Right.
So if you want to be part of the hydration group in the trust and you're passionate about hydration like I am, contact me.
Okay.
And get involved, because the more people we've got, the more opportunities we'll have to make positive changes in the trust.
Brilliant. Thank you very much.
Thank you so much, Rachel. Thank you.